Greetings. Let us learn about the use of through the scope clips in GI endoscopy. So here is a case. We are applying a clip to control bleeding, and in addition to hemostasis, through the scope clip can do a lot of different things. Nowadays there are several different companies that manufacture through the scope clip devices, and it's important to learn how to operate each of the clips. For the most part, they have a similar function and similar mechanism of action with minor differences. So let us learn about the various applications of through the scope clips. They are most frequently used to control bleeding, otherwise known as hemostasis, and after resection of large polyps to close the defects and also close perforations. So these are the two most common uses of clips: hemostasis and defect closure. In addition, in some cases, when the feeding tube keeps coming back into the stomach and you want it in the jejunum, you can go with the scope, attach a thread to the feeding tube, and secure that feeding tube. Before, the current design of clips that are available specifically to secure stents, we have used through the scope clips to secure stents. But nowadays, a lot of people are trying to use over the scope clips to secure stents, or over the scope suturing device to secure stents. And also some are trying a new suturing device that can be applied through the scope itself. So that is another application is securing the stents, but the through the scope clips are not necessarily that great for this purpose. People who do research in the colon and want to attach the manometric catheter to the transverse colon or proximal colon, they have used clips to secure them as well. Although clips are very useful in controlling bleeding, in some cases, despite your best efforts, you may not be successful in controlling a brisk bleeding. And in that case, you may decide to send the patient for emergency angiogram for coil placement. And you could assist the interventional radiologist by placing a clip close to the site of bleeding, like you've seen here. And these clips are visible on fluoroscopy, and the interventional radiologist could direct the catheter embolization to the vessels that are near the clips. First, they can identify the bleeding much faster, and if they are in doubt and the bleeding has stopped by the time they did an angiogram, these clips could help them direct their coil embolization. I also use clips after finding a cancer, if the patient is going for surgery, to place a couple of clips near the cancer site in the colon and take an X-ray, so that if the patient goes for laparoscopic surgery, the clip might help the surgeon place their ports. Clips are also useful in directing radiotherapy. By marking the site of cancer, the clip could be seen by the radiotherapist, and they could direct the radiation to the cancer. Although there are so many applications that people have come up with, the two most commonly used applications include bleeding control and defect closure. So now let us learn about how to operate a clip. When the clip comes out of the packet, you can see the handle. The handle has a thumb ring. You put your thumb into that ring, and a slider. You hold the slider between the forefinger and the middle finger. As an assistant who is assisting the endoscopist, when the endoscopist is dealing with a bleeding, it is important to make sure that your clips are readily available. You take them out of the packet, uncoil, and be ready to hand over the clip to the endoscopist in a closed position. So see where the forefinger and middle finger is located on the slider, and with this the clip is in a closed position, and if you open your right hand and pushing the slider forwards, the clip becomes open. So let us look at it. When you close your hand, the clip closes. When you open the right hand, the clip opens. It's very simple to operate a clip. So now we close and the clip closes. And now if you want to deploy, then you firmly close your right hand further, and then that will release the deploying mechanism and the clip deploys. So in other words, there are 3 different steps in clip application: open, close, and if the endoscopist is not happy, he may ask you to reopen. So you could reopen. So open, close, and then deploy. It is important to make sure that the assistant deploys the clip when the endoscopist says to deploy the clip. Why is this important? If the endoscopist applies the clip and then says close, and he is not happy with that application and the bleeding is continuing, he would want the clip to be reopened, to reposition the clip and then close it to secure the blood vessel. And once the clip is closed and the bleeding stops, then he will say deploy, and that's the time you should deploy the clip. So one should not be in a hurry to close and deploy as one step. Instead, think about clip is open, the endoscopist goes to the vessel and says close, you wait. When he says deploy, then only deploy that clip. So this is very important for a good outcome. Otherwise, what happens is if you accidentally deploy after closing the clip is deployed, you wasted a clip, and the endoscopist will struggle to find a suitable place where he can catch that bleeding vessel. The clip is occupying the real estate there and not doing the job. So important to keep this thing in mind and think in your mind, clip open, clip close, and only when the endoscopist says deploy, you should deploy. I hope you got this thing right. So now let us look at some of the things that the endoscopist does when it's closing. When it comes to closure, the assistant should close the clip slowly. It is important to learn this, and I'll tell you why. So let us look at some closures. Here is a defect. The endoscopist is applying the clip, and you can see these closures are superficial closures. These clips are not going to stay there for long. they will fall off very quickly, and the patient might rebleed or a perforation may reopen. Why do I say it is a superficial closure? Look at the two blades of the clip and look at the gap between the two blades of the clip. And when you have that gap and the clip has approximated only a quarter and the 3/4 of the blade is still not being used for closure, this is a superficial clip closure and the clip is going to fall off very quickly. So, how do we make sure that we achieve a deep closure? So let us learn about this. So here is a clip, wide open, and say for example, you close the clip. What happens? The clip retracts by a few millimeters. Open clip, and when you close, it retracts by a few millimeters. This clip retraction should be compensated so as to achieve a deep closure. So how do we compensate for that? So as the clip is open and when the clip is being closed, you should close the clip slowly. Assistant should close the clip slowly. While he's closing slowly, the endoscopist either gently pushes the scope forwards or the clip forwards, and that will compensate for that retraction, that gentle movement forwards. And this will achieve a deep closure. As you can see, there is no gap in between the two blades of the clip. So what did we learn so far? In terms of clip operation, open the clip, one step, close the clip, second step. Final step is deploy. Do not deploy until the endoscopist says deploy. That's one concept. Another concept is when you close the clip, close slowly so that the endoscopist has time to compensate for the clip retraction by gently moving forwards the scope or gently pushing the clip forwards so as to achieve deep closure. So, although clips can be used routinely for a lot of defect closures, most defect closures tend to be not that wide, but if in case you have a wide defect closure, Dr. Yahagi from Japan came up with several different concepts, and I would like to share those concepts. One is to hold one edge and then drag it to the other edge and then close, or make a mucosal incision so that the clip could anchor into that mucosal incision and then allow it to close the defect, or the use of an 8 double ring so that you attach it to one clip, attach it to one end, and place another clip in the ring and bring it to the other edge and close, or the use of a loop to close, or the use of a grasper to bring the other edge close to the clip so as the clip can grasp that, and finally using a thread with the thread to bring the edges together. And lastly, if it is a big defect and momentum is peeping through that defect, use the momentum to bring it into the lumen and close. So in summary, we have learned about clip closure, applications of clip in different areas, and the principles of clip closure. Open, close, close slowly, wait, deploy when told to deploy. If the endoscopist needs to reopen, you can reopen by following the simple rules of engagement. I hope this is useful. Thank you.